people just want to know what's happening, good or bad. I've had to be, the one to have good conversations with people when they're worried about something, but also have been the radiologist on the other side, having to give people those bad conversations when there's a problem that they had suspected was there, they had a bit of intuition, or in some cases where they had no clue was there. Our tools for early detection of neurodegenerative disorders are quite weak. We really need to advance them, and MRI is going to be one of the key imaging tools to do that because, again, it allows us to really peer into the brain with an unprecedented level.
Well, hey everyone, Dr. David Perlmutter here. Welcome again to the Empowering Neurologist. Total body MRI has become a thing. People are talking about this technology. Should I undergo this scan from head to toe using MRI to evaluate my body for all kinds of problems as a screen, for example, for cancer? Is it a good thing? Is it cost effective? What is the rate of false positive and what is the rate of false negatives, missing things? So I thought we would explore this with one of the pioneers in this technology, Dr. Raj Attariwala. Let me tell you a little bit more about him. Dr. Raj Attariwala, MD, PhD, FRC, PC, is a nuclear medicine radiologist and biomedical engineer. He holds a doctorate in biomedical engineering from Northwestern. Prior to becoming a double board-certified radiologist and nuclear medicine physician, certified in both Canada and the United States. He received his formal training at UBC, University of British Columbia, along with specialized training at Memorial Sloan Kettering Cancer Center in New York. He's also been trained at UCLA and USC. He is the creator of the Prenuvo Scan and the Prenuvo Report, which were developed at his MRI facility, AIM Medical Imaging in Vancouver, Canada. His passion is to create and advance technology to help patients understand how their body changes in both health and disease. And he's currently working to develop and implement critical tools to promote health span in Medicine 3.0 with leading scientists and physicians from around the world. I'm very excited to welcome Dr. Attariwala to the program. Well, Dr. Attariwala, welcome to the program. Good to see you.
Thank you. Good to see you as well. Pleasure to be here.
We're going to be talking today, as I mentioned in the introduction, about the value of this total body MRI and how it is, one of the tools now available for so-called early detection. But I thought a good place to start would be why MRI? What is MRI and what are its advantages? And I can't imagine, having talked with you previously, I can't imagine anyone that has more of a knowledge base in this area than you. So why MRI?
I think it's actually a great question. One of the real powers that MRI has is just the ability to use all these various, what we call sequences, which are looking at how hydrogen attaches to different molecules in the body to really see what's going on. So it's a way to peer inside the body without, any radiation. And I think that's actually a really important part. When we really talk about imaging, there's all sorts of different modalities that actually look at different things. Stepping way, way back, looking at X-ray, which is the first imaging modality that allowed us to see the bones. What we do with X-ray is we'd shine through photons of X-ray wavelength light that would shine through and just hit dense tissue such as bone. And then we would see it on the negative film that, here's the bone. So that's where imaging started. It really became revolutionary because we could see fractures and all sorts of things of that nature. And then CT, which is basically spinning X-ray, allowed us to look at bones in 3 dimensions, as well as it actually allowed us to now see soft tissues and see what their material was composed of. And then along came what was called nuclear magnetic resonance, but that came along during the, during the Cold War era. So nobody liked the word nuclear, so it was actually then changed to magnetic resonance imaging, or MRI. And the real power of MRI is, again, just the simple fact that, there is absolutely no radiation. And you can really think of MRIs, we're using it as a hydrogen imager. So our body's 70% water, so H2O, and there's a lot of hydrogen on fats. And so what we do with MRI is we actually look at the interplay of those two materials to see how the body is connected together and how various organs are composed of those different types of tissue. And one of the real beauties of MRI is the fact that, if you've ever been in one, you hear all these different noises.
And I have.
You hear all these various noises, and they're actually kind of probing or looking at different things and providing us with information about that tissue composition, what it's made of, and what it can do. And I think that's one of the real critical elements when you look at imaging. We have, going back to X-ray and CT, it basically gives you an anatomy. It tells you like what the structure of the body, just like, if we're thinking of a building, it's like the structure of a building. It's like a blueprint. It tells you where the bits and pieces are. Whereas there's a whole other field that I'm also have a specialty in called nuclear medicine, where what we do with that is we actually take a radio tracer, so a drug or a molecule that binds to a certain area, and we attach a radioactive tag to it, inject it through the veins, and see where it goes and see where it attaches to. So that's nuclear medicine, and what it actually allows us to do in nuclear medicine is to see how things work, see how quickly they work, see how things are changing, and that gives us an idea of what's happening. So I think one of the great analogies between the area of nuclear medicine and radiology is to basically imagine a building where there's all these people kind of coming and going. There's parcels being moved back and forth, and we have the blueprint of it. There's like a loading dock, a sorting dock, and then there's all these people moving around. And so the loading dock and sorting dock, we say, okay, well, that's the anatomy, and all the people moving around are the delivery people. So we know it's like a post office or a warehouse of some kind. So that's what the function is. It actually tells us what's happening in that building. So that's the power of nuclear medicine, or functional imaging, as we would call it. And when we combine the power of anatomic imaging with functional imaging, we get almost a synergy of 1 + 1 is equal to 3. Like the sum is much greater than the individual parts. And MRI as a modality actually allows us to do both. We can take anatomic imaging, tremendous detail in anatomy, and then we can actually also look at function and see how things work. We put the two together, all without any radiation, and we get a lot more information than we otherwise would.
Yeah, the detail that MRI reveals is absolutely breathtaking. For me in the field of neurology, learning these parts of the brain and the pathways, et cetera, but to see them on an image, as I remember studying anatomical sections, and they are, they're like anatomical sections. It's really quite breathtaking. This idea of scanning the entire body as a way of early detection. I mean, how effective do you think has it become? I mean, not a question. Do you think? Well, how effective is total body MRI in terms of early detection?
Well, it's incredibly powerful in terms of what it can do. As you know, like MRI, as you said, it's almost like looking through the entire body in anatomic sections without having to slice you, as we did in the anatomy lab back when we were in medical school. So as a result, you can get that level of detail. But typically, if we kind of look at the imaging pyramid based on cost, and that's usually based on time and access, MRI is kind of at the very, very top. It's usually the last imaging modality used just because of time that it takes on the scanner and also access to it. So as a result, X-rays are ubiquitous. They're relatively cheap, sometimes even in sports stadiums, and then you get to CT scanners, which are more common because they're fast. Whereas MRI, it's slow, but it provides way more information. So when we look at like the whole body, we see everything in the level of detail that really is the pinnacle of imaging in the field of radiology. And prior to putting together the whole body scan with physics colleagues from around the world, nobody thought it could be done as quickly as we did. The idea of doing an entire body with detail that we have, no one thought it was possible. But this is where I, take off my medicine hat and put on my PhD engineering hat, and realize that there's a whole world of MRI physicists out there who can do amazing things with these MRI machines. But typically, they, it's like speaking a different language. They can't actually talk to the radiologists, and vice versa. And so as a result, they would have these amazing tools built, but they didn't really know how to implement them. And that's where I came along, where I set up my clinic here in Vancouver at AIM Medical Imaging, where I thought, I wanted to do research at a very, very high level, but everywhere I looked, I couldn't do it. It was always, you can do research, evenings and weekends, and, go write grants, but, it's all about, getting through the clinical caseload, which, as we know, is expanding and expanding. So that's where I decided to buy my own MRI machine here in Vancouver so I could play with it and do my own thing. and not have all these, administrators or bureaucrats get in the way, and, really focus directly on patients. What do patients want? Because, ultimately, one day we're all going to be patients. And everybody kept coming in and saying, can't you run me through that whole thing? Can't, they'd come in for a brain MRI or a head MRI, and they'd be like, or a portion of the spine, and they'd be like, can't you run me through the whole thing? And I was like, well, they're not designed that way. The MRI machines weren't designed to do that. Whereas because I had this unusual background in nuclear medicine, where once we take a radioactive drug and we inject it into somebody's circulation, we want to see everything. We don't want to irradiate you again, just because we don't, we know what the risks of radiation are for, the induction of cancer. So we don't want to do that. So in the radiology world, it was like, well, if we look at your cervical spine and we need to see more than your neck, then we bring you back to look at your thoracic spine or your low back, your lumbar region. We just keep bringing you back. But, at this private clinic that I set up here in Vancouver, patients were paying for this. And I thought, look, my goal as a radiologist should be that when you walk out the door, you have an answer to your question. If I'm taking your money for a scan, I want to make sure that you have an answer. Even if that means being peace of mind that there's nothing bad going on, because as you know, sometimes our thoughts can get further ahead of what's actually happening. And that's what we did. And so in this room where I sit right now, I used to go through on this screen behind me with every single patient what I would see, what it would mean. And I would explain to them, because, a picture's worth 1,000 words, and they would understand everything that I knew. And they would become really the most educated person about their whole body. And that's where the whole screening started, where, I said, well, put my engineering hat on, let me talk to my physics colleagues and some other really advanced radiologists in UK and Japan and say, can we start to look at the entire body? How do we make it happen? How do I convert the MRI machine that's behind that wall here into something that can look at the whole body with a decent amount of speed? And so we did that, and I started to acquire all this technology and knowledge from people all over the world, and we implemented it right here in Vancouver. And then I would sit side by side with the MRI technologist, the person who runs the machine, or the programmer of it. And we would put together images and acquisitions. I'd be like, okay, yes, as a radiologist, I can read that, or no, that's not good enough. We need to make it better. And then we put together this protocol that is, now the Prenuvo Scan, that actually allows us to scan the entire body in the tremendous amount of detail that any radiologist would expect for just an individual body part, be it the head or the abdomen or the pelvis. And we're able to do that with unprecedented speed, just because I know the physics of it to make it happen.
Well, my scan, I think, was 45 minutes, which was hugely acceptable. And, you're talking about the cost of MRI. Isn't there the notion of cost-benefit ratio? I mean, isn't the benefit of being able to peer within somebody's body and to find things early when they can still be treated, isn't there a huge benefit to that needs to be weighed into the equation?
Oh, without question, just to know what's going on. People just want to know what's happening, good or bad. I've had to be, the one to have good conversations with people when they're worried about something, but also have been the radiologist on the other side, having to give people those bad conversations when there's a problem that they had suspected was there, they had a bit of intuition, or in some cases where they had no clue was there. And really, in those people who had no clue, like after, all the trauma that they're going through psychologically, typically about six months afterwards, once the process was started, I would always get this thank you card or a bottle of wine or chocolates or something saying, thank you. You're the only one who explained it to me. And, again, with the pictures that I was able to show them on the screen, they really understood what was happening. They understood what mattered, and I think what's really powerful and important, is to really kind of look at, the brain in terms of what it can do. I can remember like having these difficult conversations with people. Like I remember this one lady vividly, who had absolutely no idea she had metastatic stage 4 breast cancer. So it had spread all over her entire body. She had no idea. She came in and got a scan. And so I'm the one who basically had to break it to her. She was having shoulder pain or something for that reason. So she decided, look, if I can do the entire body because it's just as fast as doing a dedicated shoulder, let me do the entire thing. And so we did that. And I basically sat here and I said, look, you have it. The breast cancer spread from the breast tissue to the armpits, which is why you have the shoulder pain, into the liver, and then into the bones around the shoulder and everywhere else. And, as you can imagine, she was absolutely devastated. And what was fascinating, and I see this time and time again, is that I said, look, the only upside is the fact that you have nothing in your brain. Your brain is pristine. It's textbook. And that was the only thing that really made her, sort of stop crying, just from the sheer trauma of it. And if we kind of take the body and we divide it into what are the things that people worry about, medicine 3.0 has really done that quite well, where we divide into 4 areas. One being cancer, early detection. So that's what, I built the whole body scan for. And I use these diffusion techniques, which are functional techniques, to be able to characterize hard mass of a tumor from normal tissue. Then the next part that people worry about is cardiovascular disease. And there's like a lot of, good techniques for prevention, early detection, and treatment in the cardiovascular space. The third is metabolic. People are becoming more and more aware of that as type 2 diabetes is impacting. And the fourth one, which really, fortunately, people like yourself and others are looking at and really helping address, is that neurodegenerative disorders. Our tools for early detection of neurodegenerative disorders are quite weak. We really need to advance them, and MRI is going to be one of the key imaging tools to do that, because again, it allows us to really peer into the brain with an unprecedented level.
Well, I want to promise our viewers we're going to get back to the total body concept in just a moment. But when I visited you there in Vancouver, one of the things that was so impressive in our conversation was that you are dedicating now not just to looking at neuroanatomy, which is, or neuropathology, which is what we see when the brain begins to degenerate, but you had mentioned that you're working on technology to actually image the brain in terms of its metabolism. As my followers have been noticing over the past decade, we've been all over the notion of metabolism as being the harbinger for then the clinical manifestation, for example, of Alzheimer's, that what begins are metabolic changes in the brain long before the accumulation of the beta amyloid and the atrophy that so characterizes that disease. So let's unpack that a little bit. Where do you stand on that, and what do you see moving forward in terms of what you're planning to develop?
Right. Well, actually behind me, you can start to see some of the things that I'm starting to do in the background. But basically what we're looking at a few ways of number one, standardizing MRI machines. So all MRI machines are not created equally. The amount of signal intensity and even anatomy of the brain is completely different. So the overall size. So imagine taking a tape measure, and depending on where you go, your tape measure is different. So those are one of the key things I'm doing is basically standardizing that with particular MRI sequences. But then going into the metabolic, and particularly the functional component of it, that's where the field of nuclear medicine has built some fantastic tools. Like when we actually look at Alzheimer's, we look at, where does amyloid deposit? Where do we see it in the brain? And PET, or positive emission tomography, in nuclear medicine has basically showed us that amyloid is a drug that gets deposited there. But I think one of the real keys is that, by the time it deposits, is it too late? And likely, and so the thing is, what comes first? It's been one of the big debates, in the field of neurology for a long time. Amyloid or decreased blood flow, which comes first? It's a chicken and the egg. And so with MRI, what we can actually do non-invasively is look at blood flow to areas of the brain and see if there's a particular decrease in that area. And so those are some of the tools that I'm working on, as well as looking for key components of neuroinflammation. We know that inflammatory change from diet, stress are terrible for the body, as well terrible for the brain. We've just never really had great imaging tools to have that kind of what I call kindergarten show and tell, to say, look, here's an issue. As we like to say, seeing is believing. And that's one of the real powers of MRI. And that's what we found in the whole body. It's like, you show people exactly what's going on. You can see underneath the skin. You can see where the eyes can normally never see. And the power of that for convincing somebody to change how they behave or change their diet and improve their activity is quite powerful.
It's so powerful, and I think that our audience is really tuned in on this notion of the idea that the metabolic signature for neurodegeneration in Alzheimer's is really present 2 to 3 decades ahead of the memory failure, of the executive function decline, et cetera. The clinical markers of that we test for Alzheimer's that say, yeah, you do have it. And I've been very fond of this quote from Desmond Tutu that while it's important to pull people out of the river, if we could, it's really important to find out why they're falling in the first place. And that is, if we can identify, like you say, these metabolic issues on the front end by people being screened, then we can intervene to improve metabolism, to change the diet, to increase exercise, improve blood flow to the brain, and improve glucose utilization. We can, as you know, we have scans that can look at the brain's ability to utilize ketones and compare that to PET scanning, fluorodeoxy glucose scanning, how the brain is able to use or not glucose as a fuel early on. And these are predictors, I think, of future cognitive decline. So when you explained that to me when I was up there, I thought about that for my whole way home. It's really breathtaking to think of where this is going to go, where the marriage comes between how we improve brain metabolism and your ability to demonstrate that it's dysfunctional, first of all. So can't wait for that. As promised, let's get back to the total body MRI.
For sure.
And what are the big players in terms of what you're able to detect early? What are you finding? What's the data showing?
Well, I think one of the greatest things that we were able to show, we published last year in the Journal of Alzheimer's, as well as Journal of Aging and Disease, is increased muscle mass throughout the whole body results in increased brain volumes. So the actual structure of the brain increases, or is higher in those who actually have increased muscle mass. One of the other things which is fascinating is like increased visceral fat. So that's the deadly fat or belly fat, the fat around the organs, in the abdomen. You have increased visceral fat, you have decreased brain volumes. And we found that in over 10,000 people that, age matched, that if you have increased visceral fat, you're going to have decreased brain volumes. And again, the question is why? And it really pertains to the fact that, fat comes in different forms, it deposits in different locations, and that visceral fat around the organs is really quite a pro-inflammatory organ. And it basically results in increased inflammation throughout the body, has all sorts of deleterious effects, particularly as it pertains to things like metabolic syndrome. So type 2 diabetes risk is higher with increased visceral fat. And as well, we're now seeing that impact on the brain. And I think one of the real powers of that whole body scan is that previously in the field of medicine, we've actually divided and conquered. And that probably wasn't a good idea. We actually kind of need to look at the entire body together, because that's ideally what patients want. That's what we want. And, who would have thought that, the belly would affect the brain? Well,
or muscle mass.
Or muscle mass, and I think like the funniest thing is like when we published this or came up with all this data, one of my colleagues basically laughed. He said, well, yeah, you guys have proved what every grandmother has always said. Kids, get outside and play, keep moving. Your body's meant to move, and by moving your body, increasing muscle mass, it keeps your brain healthy, so it's quite ironic.
What you've demonstrated is a correlation. There's a correlation between higher muscle mass and higher brain volume. It's a correlation. It doesn't show causation, of course, no. But I feel that I'm going to say that, yes, there is a causation, and hold my feet to the fire if a person wants to. But we fully understand that various chemicals made from muscular activity, like lactate, interleukin-6, BDNF, cathepsin B, irisin, for example, all have effects in the brain that are positive. And, the muscle, therefore, is like an endocrine gland. I've talked to this audience about this quite a bit. And, then we look at the correlative studies with respect to dementia risk based on the number of steps an individual takes per day, or the number how often do they engage in vigorous exercise. So I think, there's enough there for us to say that, yes, building muscle mass is probably a good thing, that your grandmother was right, get out and play. But building muscle mass is a good thing for your brain. Oh, and BTW, having all this fat around your viscera, is not, it's a correlative thing as well. But we know that this fat is, increasing the production of these inflammatory mediators that damage cells in the brain called microglia that then can't do their work. And as such, yeah, it's correlated, but I'm saying it's causative just because I want to. So there you go.
No, exactly. And I think like the steps I'm now working on it is just the fact that if we kind of look at this, let's call it the tsunami of what's going to be coming with the dementias. We need to be able to figure out how to find it earlier, how to effectively stop it, and also how to convince people like, look, you need to do something before it's too late. If we kind of look at where, a lot of the anti-amyloid drugs are right now, unfortunately, they're not really working. I think I was at the American Academy of Neurology last April, and I think probably the saddest statement that I ever heard from neurologists was, when they basically had to tell family members of a loved one who had Alzheimer's that, look, with all these drugs, the patients would ask, or the family members would ask, when are they going to get better? And the answer was like, they're not. And I think
that on this platform, they're probably not. And, the platform that focuses on beta amyloid, it's a real situation of, the definition of insanity is doing the same thing over and over and expecting a different outcome, Albert Einstein. And I think we've got to look upstream of the beta amyloid and really target metabolism. And really, as what you're working on, the idea of understanding brain metabolism on the front end before a person is cognitively impaired is where we need to be. Not wait till you're cognitively impaired, then hope that there's a cure for that problem. Live your life however you choose. Yes, your blood sugar matters. Yes, your activity or sedentarity matters a whole lot. And, these are things we emphasize now. And yet, I don't mean to sound really cynical, but it seems to me that there are forces that would rather us live our lives how we choose and get sick and then come along and hopefully fix our problems. But, well, hi, everyone. Dr. David Perlmutter here. We hope you're enjoying this content. And if you would do so, go ahead and hit the like button. And if you're not already a subscriber to our channel, please consider doing so. We're really grateful to have you as part of our community. So let's get right back to the presentation. What are some of the pushbacks on, you've developed this amazing protocol of total body MRI that is, I think, breathtaking in terms of early detection, in terms of understanding what's going on within a person. But what kind of pushback does the medical community offer in terms of why people should not do this?
Well, I think one of the most common pushbacks is really the risk of false positives. If you see something, you're going to scare patients and, oh no, now it's going to result in a bigger burden on the medical system down the road. And I think that is justifiably true because right now we don't actually have all the statistics on what those false positive numbers are. I have some colleagues in Europe who actually have been doing, the total body scan as well, based out of Milan for quite a while. And they're actually great in the fact they're compiling all this data to actually get those false positives. And, they roughly, this is early days, not published yet in peer-reviewed journals, but it ranges between around 4%, plus or minus 2. And when I was at Prenuvo, we were sort of looking at some of this data as well with a lot of follow-up data. And what was actually fascinating to me is that I could actually geographically locate where people were based on their scan findings. So,
in other words, in terms of who is interpreting it?
Well, actually, in terms of like the severity of disease that people would actually have and manifest. So, for example, like the people in the Midwest, you could see more spine problems based on labor, more labor activity in the San Francisco area. You would see more cervical neck problems, C5-6, which is the flexion of the head and the neck. Wow. You would see that, they call it tech neck because people are on their computers looking down all the time. So you could see all these things. And, we kind of came up with around as well about a 4% false positive rate, which quite honestly, in the field of imaging, that's amazingly low. If you were to look at mammography for screening, it's, a little bit better than flipping a coin in terms of sensitivity and specificity. So what we actually would do in mammography is we say, look, we see something, called a shadow, which is the most common term on X-ray. With mammography is a weakened X-ray. We see a shadow, come back in 3 months and we'll look again. And we'll look
more
again.
Radiation.
Yeah, and granted, it's one of those cost benefit or, risk benefits of, the benefit of finding, breast cancer early or any cancer early outweighs the risk of that little bit of radiation. Again, it is radiation, unlike MRI. So, this has existed in mammography that, if you have a problem, or something we're not sure about, we'll just wait 3 months, come back again, and we'll see if it changes because cancers will grow. Whereas if it doesn't, okay, we'll now come back in 6 months' time and we'll see, if it's changed again, because we know that we've captured the fact that at 3 months it hasn't grown quickly, which means it's not an aggressive tumor. And I think that's actually quite important when we actually kind of look at staging in cancer. So you have 4 stages. So stage 1 is where it's confined to the organ of origin. Stage 2 is where it spreads to the adjacent tissue. Stage 3 is where where any cancer can advance to like the regional organs. And stage 4 is the metastatic disease where it goes everywhere in the body. So with mammography, when we do the screening, the whole idea is that we get women to come back in 1 or 2 years, depending on the risk factor, with the idea that if you had a mammogram and the next day a tumor starts, it will still remain in stage 1 2 years later, right? Because it's going to grow relatively slowly. So that's one of the key things of, sort of, let's call it actuarial medicine, where medicine is really kind of governed by, the payer, that the benefit for the great population as opposed to the individual will basically outweigh the small risks of missing something that's growing very quickly.
Let me ask you, how does the total body MRI compare in terms of its sensitivity to dedicated regional MRI? In other words, I looked at my brain images and I pretty well was satisfied that, that was a great brain MRI. But, in looking at my spine and my knees and pelvis, et cetera, how far away from a dedicated MRI of those regions is the total body MRI?
So the total body MRI, like we really did focus on basically, the head to pelvis. So all those are equivalent to what you would get for a dedicated scan of each of the individual body parts. And when we get into the joints, like the knees or the hips, there's a special sequence that can be used to look at cartilage. So we can tune the MRI to look at cartilage, and we don't do that, again, just because of time. So for the individual joints to look at the cartilage or the cartilage thickness, that isn't done. And the reason why is because early on, when I was doing this, well before Prenuvo, we would have these in there, and then the orthopedic surgeons, the ones who would look at the knees, would be like, well, look, it's like when I see the entire study, the knee is so small, it's like I can't zoom in on it to view it any better. And it's really the fact that, typically when we view MRIs, we actually don't use a zoom feature. We don't use a pinch and zoom feature at all. And you'd be like, no, you have to zoom. And their viewing systems didn't allow them to do that with MRI because you normally never do. So the crazy little logistical friction of zooming with an MRI is the entire reason why we didn't put it in. So it was removed. So dedicated knee or joint MRIs are still better than what the total body scan can do. It could be added, but we'd have to modify the sequences to get a little bit better to be able to do that. Whereas any MRI can do that now. So, there's no point, us focusing on
And the screening test is a non-contrasted study, right?
Correct. Yeah. So the whole idea behind screening or early detection is you don't want to be doing anything invasive, be it with the brain area that I'm working on or cardiac stuff that I'm working on as well. We just do not want to be doing any injection because that sort of defeats the purpose of a screening. So that there's no injection whatsoever.
And who can't have an MRI?
So people who can't have an MRI are those people who basically have metal that, because again, MRI, big magnet. If you have like metal that's implanted in certain areas or has come to certain areas from working, such as machining grinders, like let's say a grinder or somebody got some metal in their eye, well, the last thing we want them to do is to go into a very powerful MRI machine because it can actually go and move that piece of metal and could tear the back of the eye. Same thing if somebody has, some iron-containing metal in the brain, some really old brain aneurysm clips that people would use that's spring steel, which contain iron. So if it moves in a magnetic field, it could be a problem. As well, people with pacemakers or other implanted electronic devices. Nowadays, most things like hip replacements or knee replacements, they're all titanium, so they're not iron-containing metal, so they're not magnetic. But every MRI facility, no matter where they are, for any body part or a total body, whole body, or Prenuvo Scan, we screen to make sure that people are safe for that.
So when you do that, you have to get the brand and model of the knee implant or hip implant that they've had, so you can be sure that it is fully titanium and not going to be ferric.
Right. Well, if it's most all the new implants are all titanium, but some of the very old ones may contain. And so if it's within a certain, let's say, decade or even 15, 20 years, we know they're fine for joints. But where we still need to be very cautious of is, pacemakers and things of that nature, which you can't have an MRI for. And as well, the iron in the eye, that's very important. Little flecks of iron, we don't want them to move.
And what about tinted contact lenses?
I don't think they're a problem. Not that I know of.
So let me ask you about the interpretation of these scans. How standardized? I mean, these are done by radiologists. So how standardized or how much unanimity is there in the interpretation of the? I mean, ultimately, it's somebody reads the scan, and how are the results lining up in terms of comparatively one radiologist to the next?
Well, actually, it is quite a steep learning curve for a radiologist coming into it, and this is part of the reason why the scans that we put together have like a lot of redundancy. And what I mean by that is there's actually a lot of redundancy in the sequences, so it actually allows radiologists to build on what they're comfortable with, things that they actually understand. So a lot of radiologists will be, we're all good at the brain, like, that's sort of bread and butter. But then when we get into the abdomen, so what we call body radiology and MRI, not a lot of people do that. It's not as common. So as a result, the people are learning, the body MRI based on their CT knowledge, or, the fact they've had a bit of exposure. And so that's where they learn and they build on what they know. So they're quite good at what they know. But then what I've added is this diffusion sequence, which is a functional sequence, which really kind of looks at where the problem is. It basically kind of is able to look with imaging for a hard lump, a hard mass. So how when people palpate your body, they're feeling for a hard mass, which is tumors. So just like they used to tell women, feel for your breast, feel for a lump. Well, that's what this functional MRI sequence called diffusion can do. And so that sequence, most people have never seen before. And so it's always kind of interesting when I look at, when I watch them or train them, the new radiologist would say to me, it's like, oh, what's that diffusion sequence? I've never seen that before. Are you doing a nuclear medicine study as well as the MRI? Are you doing a PET scan? It's like, nope, that's just diffusion done well. That was taught to me by my physics colleagues in UK. And I watch after about 20 to 50 scans, all of a sudden they kind of change and they get it and they realize how powerful that functional sequence is. And at that point, now you've sort of hit this standardization and they're ready because now they can see this new thing kind of layered on top of what they're used to. And that really allows them to build confidence to get to that 1+1 of anatomic and functional imaging combined together, that 1+1 = 3. And that's when you know that, okay, this radiologist is ready. But I think going forward in the future, as whole body MRI expands and there becomes more and more demand for it, I feel there's actually going to be fellowship trainings and education just for that type of scan. I think one of my colleagues at Prenuvo, he'd said a while ago that the term which I said, primary care radiology. And I really think that will likely be coming. And that's actually already starting to happen in Italy and in parts of Italy. This is occurring. So my colleagues there who do whole body MRI, it's becoming primary care radiology in Italy. So it's just a matter of time, really. It's, as the equipment gets better, the processes get simpler and faster. The demand for it is out there. It's enormous. And as a result, the equipment will start to get better and better to be able to do this.
Do you foresee a time when the data will simply be analyzed via AI and interpretation will be rendered?
I think so, yeah. And I think I definitely think that will come, but I think there's actually a lot of technical challenges there. And it's actually not really on the AI side. It's actually more on the MRI equipment side and the standardization side.
Really?
Yeah, I think that's actually the biggest problem is the fact that no two MRI machines are unique in terms of what they do, in terms of the image or the picture that they provide. You actually get all these distortions that can occur because you're in a big magnetic field. And as a result, there's really no standardization. So what's fascinating in the early days before Prenuvo, we actually were building what are called phantoms, or they're inanimate objects that we would put in the MRI machine, and we would actually scan them and start to see what the distortions were, and we could really measure these. And we would get machines that would come off the assembly line one after another, and you would see that they weren't identical. So what that meant is, if I was to take a cross section through the abdomen, it would be, let's say, I don't know, 32 centimeters on one machine. On the other one, it would be like 32.6. Well, then if you go and you add bowel gas to it, it would be even worse. And then if you were at the edge of the field, it would be even worse because you kind of get this flaring from the magnetic field. And so because of that, that's what we call geometric distortion. That's going to be the biggest limitation to AI, because this geometric distortion is present in every single machine. And that's where you want to have a bit of consistency. And one of the really neat things that I'm working on, particularly in the brain, is I'm working with a person. His name is Professor Mark Hakey. So I call him like the Bill Gates of the MRI world. He wrote the language that every MRI machine runs on. He understands how they work better than anybody else. And he's built some specific sequences that we're working with that actually get rid of all of those problems. What it means is, if you get a scan here at AIM in Vancouver, and with that sequence, and you get a scan at any MRI machine, be it a 1.5 Tesla, a 3 Tesla, a 0.5, the anatomy and the measurements will be identical. And not just the measurements of dimension. So imagine your tape ruler now is identical, but also the signal intensity. So how bright something is or how dark something is will also be identical and machine independent. And that's where the real power of MRI is going to come in.
Yeah. And, you mentioned these magnets, the Tesla, the strength of the magnet. And there seems to be a push that, we have a 3 Tesla magnet. Don't go across the street. They only have a 2 Tesla or 1.5 Tesla magnet, whatever it is. And I think you've stated that that's really kind of erroneous, that the strength of the magnet is interesting, but that you are actually out of a 1.5 Tesla getting some incredible images. And the notion of, this MRI center across the street has a bigger magnet, that, it's an advertising piece, but it really doesn't have relevance.
Well, it's a balance of speed and the real physics, and I think like that's kind of where a lot of the issue comes in, is that most people really don't understand like the real hardcore physics and technology that's, underneath the covers of an MRI machine. And so if you look at how it works, you have an electromagnetic wave. So if you were to take a 3 Tesla MRI machine, that electromagnetic wave is roughly 15 centimeters, or the width of your head. So therefore, when you actually do that in the body, it's not quite wide enough. Whereas if you go to 1.5 Tesla, now you're at 30 centimeters, which is like the width of your shoulders. So as a result, at that lower 1.5 Tesla magnet, you're able to penetrate through the body quite easily without constructive and destructive interference. And also heating is a big issue. The heating goes up 4 times at 3 Tesla compared to 1.5. So you have this balance of heating. So, if I was to do, for example, a brain MRI, without question, 3 Tesla will be faster if your magnet is tuned well. And I think that's a real key, is the fact that, if your magnet isn't tuned very well, it doesn't matter what kind of magnet you have, the images are still going to be lousy. And if there's no real standardization for how you tune your magnet, it's not going to help. And so that's where, sort of being an engineer and knowing the MRI physicist, we know how to tune this machine, and as a result, we can, get images off of a 1.5 machine that look as good or even better than the 3 Tesla machines, and I'm working on sequences that can be as good as 7 Tesla off of a 1.5 if you're to look at detail and resolution. But it's that balance of, detail that you want versus time. So that's where the static field of that Tesla can really be powerful.
I recall when we built our first MRI center here in Florida, that we had these discussions, and we were basically at the mercy of the salespeople to tell us what we needed, what we should have, and we did not have any degree of understanding about those parameters that you just described. We'll also say that I was quite fascinated when I visited you that we went to the back of the MRI where you had your cooling system, and I think you said it was something like 6 degrees above absolute zero.
Right.
Something like that?
About 3 degrees above absolute
3
zero.
degrees above absolute zero.
Right. So yeah, minus 270 degrees Celsius, or that's minus 500 and something Fahrenheit. I can't remember. That part of my engineering mind is forgot, and I don't think it's Alzheimer's yet. I just forgot.
We'll talk. That said, what are some of your success stories then? What have you found with this total body MRI? What's the spotlight on? What do you talk to people about?
Well, for the whole body MRI, it really is for, let's call it one of the four horsemen in medicine 3.0. It's cancer and early detection. And so that's where the real power is, particularly to find a cancer in stage 1, confined to the organ of origin or the site where it started. Those are the big success stories, because statistically all the data is there, that patient will do well. And those are, we see that a fair amount. So again, depending on how often do you see cancer in a otherwise well population, our Italian colleagues, they're getting around anywhere from like 2 to 6%. We were getting the same thing. And it really depends. For example, firefighters, they're at increased risk due to inhalation. So we're seeing a little bit higher in those numbers. And other people just based on exposure. And, obviously in the people with the genetic predispositions, it's actually much, much higher. And that's actually where a whole body MRI or total body MRI has really, sort of come to like the limelight, has been in the pediatric world, where patients who actually have this, like a Lee-Fraumeni syndrome, it's like the de facto standard for how to screen these young patients. Because as a young patient, you don't want to expose them to radiation. So as a result, you want to use an imaging modality like MRI that has no radiation, but has the amazing resolution and detail that you can see.
Well, we know that for looking at colorectal cancer, there's colonoscopy. There's also the virtual CT, which is computerized tomography. How effective is MR for looking at the bowel for colonic issues?
Well, we'll still see colon cancer in what we call stage 1. So that's where it's, again, confined to like the wall, but depends on the size. So the real power is actually getting it before it's cancer. And so that's where colonoscopy still becomes, the best tool. Because basically with virtual colonoscopy or conventional colonoscopy, the most difficult part about it is really the bowel prep. It's somewhat unpleasant. And if you're going to do that bowel preparation, do it for the best test, which is a colonoscopy, because when the scope is in there, if they see a precancerous polyp, they can snip it out and it will never turn into cancer. And so that's really the best, is knowing that you can get it at that stage. So I still always tell people that, sure, total body scan with diffusion, has to be with diffusion, that functional technique, you can detect colon cancer early, but still the best is colonoscopy.
So what would ride along then with a total body MRI scan? In other words, what adjunctive, if a person wants to do his or her best to screen for all kinds of pathology, is there a blood test or a panel that you're going to work with that can give you more information, correlative, that might be helpful? And the reason I ask is I just did what's called a Gallery test, and it came out negative, no cancer. But what works for you? What do you think that might be appropriate to do along with the Prenuvo scan or total body MRI?
Well, I think with the total body MRI, obviously for women, you have to have mammography, because calcification, which occur in mammography or in seen well in mammography, will not be seen by MRI. So as I mentioned earlier, MRI is a hydrogen imager. It doesn't see calcium at all. Basically it's a black hole. So for women, you must have mammography in addition to MRI as an imaging modality. Now, for men, we might as well consider the prostate our unique organ for the male sex. And so for that as well, you need the blood panels of PSA, which you want to correlate together with, with the size of the prostate gland. Then I would actually kind of look more at the metabolic markers for which MRI right now isn't that great. So our usual type of things like hemoglobin A1C, as well. I think inflammatory markers, non-specific inflammatory markers such as C-reactive protein, I think are incredibly valuable. As well, I think we actually need to improve how we detect cortisol levels. The stress values of cortisol, like right now, we just really have the AM cortisol or 24-hour. That's not quite good enough because we do get these curves. So those areas need to be improved. And then I think on the cardiovascular side, I think there's a lot of the tests are actually quite good. But really, one of the key areas is this inflammation. I think chronic inflammation, which therefore our body responds with like chronic high cortisol levels, that's a big problem. And we know that increased cortisol leads to that predisposition to the body being in this kind of, prepare for hibernation mode, if you will. That sort of prepares for the let's store visceral fat, let's store fat in the liver, and there are certain people based on their genetic predisposition who actually have that risk of increased fatty liver, who have that what we call skinny fat in the metabolic world. And that metabolic world, I think, is very, very intimately tied with the cardiovascular disease.
So you do get a pretty good image of the liver in terms of looking at fatty infiltration.
Without question, yeah. You see the fatty infiltration, you see the entire liver quite well. And there's an MRI technique or sequence, it's called out-of-phase imaging, which basically looks at within a little pixel. So, imagine your TV screen, you now have these 4K monitors, but within that little pixel, you can basically look at, is there water and fat present at the same time? So you're actually able to get the most detailed resolution of what's in the entire liver with this out-of-phase sequence, if there's any fat present. So we'll see it well before you'll see it on any other imaging modality with the total body scan. Yeah.
Well, Raj, thank you for spending time with us today. My second time with you, and I'm as I mentioned earlier, I'm sure it won't be our last. So we'll update in a year or two and see what you're up to. It sounds like you've got some really exciting things in the future, in the near term, actually, in terms of Medicine 3.0 and the collaborations that you're people that you're working with. Looks really exciting.
Yeah, no, thank you. Well, like I said, I think the world of neurology is really, as we know, it's preventative neurology. I've done that in the total body area, preventive total body, but now it's time for total body or total brain preventative, and that's the goal of what we're building, and it's able to make it scale out almost everywhere. So that's what I'm working on, because as we know, neurodegenerative disorders, they're quite devastating for people and families in particular, and that's what we want to prevent.
Well, I think we can let the audience know that the work that I'm doing with reference to brain metabolism, that we're all over what you're doing right now, and I suspect there'll be a collaboration. We'll get to use the technology that you're developing at some point in the future. I'm very excited about it. Can't wait.
Yeah, likewise. I see a lot of synergies because I think we know the field of neurology, preventative neurology, it really needs it. There's a lot of us who have to get the work done, but once we do, the impact for society would be enormous.
Step by step. All right, man. Thanks for joining us, and I'm going to promise to our audience that we're going to have you back on the program.
Definitely. All right. Well, thanks so much. You have a wonderful, wonderful summer.
Okay. Bye for now.
Take care. Bye now.
Well, we learned a lot today about total body MRI, and as mentioned, I underwent one myself. And I'm very glad that I did. The scan I underwent was called a Prenuvo Scan, Prenuvo. They're around the country, at least here in America, something you may want to be interested in after watching this podcast. But I think we're going to see this science continue to evolve as a way of early detection, as a way of screening, and I think it's got great value. Thank you for joining us today. I'm Dr. David Perlmutter here on The Empowering Neurologist, and we will be back soon. Bye for now.